এখানে সেটিং আপ করছি। We are going to start in কত 2-3 মিনিটে we will start I think না অমিতাভ we will start in 5 minutes 5 minutes এ শুরু করছি হ্যাঁ so please একটু have just a little bit of patience. We need two seniors to be
দিদি আনমিউট করে নিন।
Okay, I hope we are all audible from here. শুনতে পাচ্ছো অভিজিৎ দা?
হ্যাঁ শোনা যাচ্ছে দিদি।
হ্যাঁ শোনা যাচ্ছে, শোনা যাচ্ছে।
ঠিক আছে, থ্যাংক ইউ for attending this West Bengal Academy of Pediatrics clinical meeting, which has very kindly been hosted today by Narayana Superspeciality Hospitals. We have, I think, a very nice list of cases, very interesting, a little bit different from what we see from day to day, this being a super specialty hospital, and particularly famous, as you all know, for cardiac specialties. So I would like to hand over to Dr. Amitabh Chattopadhyay, who will subsequently moderate the rest of the meeting. And I'm thankful to Dr. Devjani Gupta and Dr. Prashanjit Ghosh for being the judges for today's meeting. Thank you.
Good afternoon, everyone. Thank you. A big thank you to Sushmita Madam and the West Bengal Academy of Pediatrics. Today's clinical meet, monthly clinical meet, is being held at Narayana Superspeciality Hospital, along with the Pediatric Cardiology Department, Pediatric Intensive Care Department, and the Narayana Multispeciality Hospital. And we have representatives from there as well. So thank you everyone for attending the conference either in person or via the Zoom link. Today we have a collection of beautiful cases, and the first presenter is Dr. Pratima Yadav. She's our fellow. She's she holds a dual citizenship almost, and she'll be talking about saving lives with bedside procedures. Dr. Pratima Yadav, who is a fellow in pediatric cardiology from Narayana Superspeciality Hospital. Pratima, come up, please.
Thank you, sir. Respected judges, good afternoon to all. I am Dr. Pratima Yadav, currently working in the Pediatric Cardiology Department Hospital. My topic for today's presentation is saving lives with bedside procedures. As doctors, we are all well aware about the importance of early referral and timely intervention in the patient survival. Today, I would like to tell you two stories about two whose early referral and timely intervention brought them back from a near fatal situation. My first story is 2022 at around 4:30 to 5:30 p.m. when we were about to wrap up for the day. Anxious parents with a sick-looking baby and a chest X-ray admitted to our OPD. The baby was Priyam Naikar, 3 months male, who had breathing difficulty for last 2 days and decreased feeding for 3 days. On examination, he was irritable, sick-looking, had increased work of breathing, tachypneic with respiratory rate of 56 breaths per minute, saturation maintained at 95% on room air. He had tachycardia with heart rate of 180 beats per minute, muffled heart sounds, and feeble pulses. This was the chest X-ray that the parents showed us, which showed the chest X-ray showed cardiomegaly with normal pulmonary vascularity, and he had been referred from outside hospital in suspicion of the cardiac condition. So, being pediatric cardiologists, we had echo handy, so we decided to do the echo of the patient. When we put the probe on the chest wall of the patient, this is what we saw. The entire heart was surrounded by a massive amount of pericardial fluid. The heart was swinging in the fluid. There was early diastolic right ventricular collapse and a late diastolic right atrial as well as the left atrial collapse. The baby had cardiac tamponade. So immediately, we counseled the parents to admit the patient in the PICU as we needed to get the fluid as soon as possible in order to save the life of the patient. So we took the patient to the access, started on IV fluids, secured the airway with elective intubation, and prepared for emergency pericardiocentesis on the bedside itself. We asked the nursing staffs to ready all the instruments that were required for the aspiration of the fluid. These are the major instruments that we had used that day. A puncture needle, a puncture wire, a 4 French sheath with the dilator, a 4 French pigtail catheter with the wire. Now we position the baby in a supine position, and we prefer to go through the subxiphoid approach. We punctured with the help of a puncture needle with a 3 cc syringe with normal saline in it. Keeping it in negative suction, we went towards the left shoulder from the subxiphoid approach until the fluid came into the syringe. After getting the fluid, we removed the syringe, we put in the puncture wire, removed the syringe, then over the puncture wire, we put in the sheath. Through the sheath, we put in the pigtail wire so that we could drain out the pericardial fluid. This picture down here, it shows the exact scenario that looked in the PICU that day, except the dummy being the baby. We aspirated about 1 ml of pericardial fluid and sent some fluid for fluid analysis as well. After draining of the fluid, we kept the pigtail catheter in situ for the next 48 hours so that we could drain any further accumulation of the fluid. Post-procedure, baby improved clinically, vitals became stable, normal breathing pattern with little respiratory support. This was the post-procedure chest X-ray, which shows a pigtail wire has been kept in situ for further drainage of the fluid. We also did an echo, which showed there was no further effusion. The fluid analysis showed cell count 651 per cubic millimeter, polymorphs 45%, macrophage 10%, that was suggestive of bacterial pericarditis. Treatment that we gave in the hospital, we started on empirical antibiotics, tazobactam, ofloxacin, and finally, 1 or 2 days later, we discharged the patient on request with advice to continue the antibiotics up to 4 days and come for follow-up later on. My next story, it was on a Sunday afternoon when a baby, Ali Hussain, 2 months, 20 days old, presented to us in the emergency department with complaints of bluish discoloration of palm and sole since birth. The baby had been referred from the outside hospital and was in a very critical state. He came in with the ET tube in situ. On examination, he had poor reflex and activity. He was severely cyanosed, heart rate 160 beats per minute, feeble pulses, respiratory rate was 76 breaths per minute, saturation 40 to 45% on room air. So immediately we took the baby to the PICU. He was re-intubated as the tube had been displaced, put on mechanical ventilation, started on IV fluids and inotropes as required. His ABG showed metabolic acidosis with hypoxia and was managed accordingly. The X-ray of the baby showed dextrocardia with egg on string appearance and increased pulmonary vascularity. This was typical for transposition of great arteries. We did the echo. The echo showed it was a case of situs inversus dextrocardia with intact ventricular septum, no PDA, regressed LV, and a very small PFO that was the only life-saving shunting for the baby. So we only had one option to save the baby, that was to enlarge the PFO. Immediately, the doctor on duty informed all the pediatric cardiology team. We were all gathered within half an hour, and then we planned to go for emergency balloon atrial septostomy. Any further delay we would have lost the patient, so we decided to go for a bedside procedure. This is the PFO of the baby, which is almost very, very small. For the preparation of the emergency balloon atrial septostomy, these were the instruments that we used: a puncture needle, a puncture wire, a 6 French sheath and the dilator, and a 6-size Fogarty balloon with a stylet. We positioned the patient in supine position with all antiseptic precaution and antiseptic painting and sterile draping. We went through the femoral puncture, femoral venous access. By the modified Seldinger technique, we introduced the sheath, femoral sheath, and through the sheath, we took the 6-size Fogarty balloon from the This is how we dilated the balloon within the heart. This the balloon has been dilated. This occurred within the heart, but we are just showing for your knowledge. Now this we advance the balloon from the IVC, as you can see in the echo. From the IVC, the balloon is entering into the RA. From the RA through the PFO, the balloon is entering into the LA. In the LA, in the left atrium, we dilated the balloon and opposed it to the left atrial septal wall. And with the brisk movement, we just pulled the balloon back from the LA into the RA, thus enlarging the PFO. As you can see in this echo. Here we are pulling the balloon into the right atrium. After a balloon atrial septostomy, the PFO was enlarged. There was a laminar bidirectional flow, and the size of the PFO 5.6 millimeter in diameter. This is the size of the PFO. Post-procedure, the baby's room air saturation increased dramatically from 40 to 45% to 75 to 80%. Gradually, over time, the patient was extubated and finally discharged with advice of follow-up after 14 days. So from these two cases, my take-home would be cardiac and transposition of great artery with intact ventricular septum are cardiac emergency conditions. Referral to a cardiac center as soon as suspicion arises does wonders in patient. Intervention with a simple bedside procedure can dramatically improve the chance of patient survival. Thank you so much for your patience hearing. Thank you.
Thank you, Pratima.
Question answer now or again? After this, okay. So, Dr. Yadav, I have two questions for you. You want to just cover this interview, then I can see you. Yeah. So my, no, I'm loud enough. I have two questions for you. With regards to your first case, right? This being a tertiary care center for newborn and pediatric cardiology, how common is bacterial endocarditis with cardiac tamponade encounter? That's number one. And the number two question for you, the topic of your talk was saving lives with the bedside procedure. Well presented, and the well chosen pieces well presented, and very neat slides. Could you tell me, this was a very sick-looking 3-month-old infant, tachycardic and tachypneic, who came to the emergency and had a procedure done in PICU, the pericardiocentesis, and echo was fundamental to the diagnosis. So could you tell me the time lapse between, where do you receive the patient, the triaging of such a sick patient, the stabilization, and then the bedside procedure? I think that deserves a separate mention. Because we went straight to echo and pericardiocentesis, but you have a sick infant who needs stabilization. So where was stabilization done? ER, en route to PICU, in the PICU? You want to just comment your comments on that and the incidence of tamponade with bacterial pericarditis?
To the answer to your first question, bacterial pericarditis, we do not have much encounter of such cases. These were, I think, 5 to 6 cases per year, I think. We encounter patients of cardiac tamponade, not much. And of that,
bacterial endocarditis associated?
Sorry, endocarditis, no, sorry, pericarditis.
We have a,
No, madam.
we have a focus, a primary
No.
focus.
No, we did not get a culture positive. I mean, it was just suggestive of pericarditis. Bacterial pericarditis. We did not get a culture positive.
Culture was negative, but the nature of the fluid from it was not a transit, it was an exudate. Culture was negative. But and the second question, you answered the second question.
And the second question, ma'am, the patient was in the came to the ER. Immediately he was transferred to the PICU, and for the time being he was ventilated by bag mask ventilation. He came to the PICU. We immediately intubated the patient, and then we started on IV fluids, inotropes after securing the IV access.
Thank you.
Usually, as soon as any pediatric patient lands up in the ER, the first phone call goes to the person on call. So they immediately tell them, they go and see the patient, assess them. If they see that the patient has to be transferred to the PICU, the time lapse is approximately 10 minutes. So they bring to the PICU and
That answers the question. Dr. Gautam,
yes, sir. Yes.
Sorry, I am only a general pediatrician. Question for the first, what is your experience of having acute pericarditis or pericardial effusion of acute presentation within days, within hours, and pericardial effusion within weeks? What is the common presentation you get? Pause. Is bacterial pericarditis so common in men? So that was the first issue. The second question, let me give. Why was the metabolic acidosis? Case number 2.
For the answer to your second question, why was there a metabolic acidosis? The patient had only minimum amount of shunting from that is to the PFO. So baby was in severe hypoxia. So in the hypoxic condition, there was a because of anaerobic anaerobic metabolism, there was increased production of lactate leading to metabolic acidosis.
There was no sepsis.
Census, baby was very much lethargic. He had very poor reflex activity.
There was no sepsis.
No sepsis. No, sir.
At that point of time.
At that point of time.
So I think the answer can be given in two ways, sir. One of the things is, first of all, the baby was in a very low cardiac output state because the heart was floating inside. As you can see the picture, the cardiac output was low because by virtue of the tamponade. That was the first reason. And the second was there was ongoing sepsis as well. So the lactic acidosis here can be explained by two sources, both of the sources.
Okay.
And in the first baby, once you had drained and given antibiotics, it never recurred and follow-up has been slow.
Yes, ma'am.
Sorry. The patient did come for follow-up after he just came two days back. We saw the patient. Patient was clinically stable and there was no further pericardial efficiency.
Actually, madam, what we do is whenever we are tapping the pericardial effusion, we leave a pigtail catheter inside for about 2 days. So the first day, approximately around 140 ml of fluid was taken out. We kept the pigtail catheter. The next day morning, we again took off approximately 37 ml, 35 ml. Third day, when nothing came out, we took out the pigtail. But it never recurred. It didn't recur.
Thank you.
The second case is by Dr. Pratap. He's our second year PGT. He is doing DNB pediatric cardiology. So his topic is stenting in the newborn, navigating through the stop.
Good afternoon, everyone. Myself, Dr. Pratap, a pediatric cardiology fellow, Narayana Superspeciality Hospital, Howrah. Case for my presentation is stenting in the newborn, navigating through the storm. This was a baby referred from Medical College, Kolkata, 1 month, 24 days old female baby. Case of cyanotic congenital heart disease, weighing 2.8 kg. On arrival, baby had central cyanosis, mild tachypnea, and otherwise baby was active and alert. On examination, heart rate was 136, peripheral pulses were well palpable, and blood pressure was 82/46, mean BP was 58. On auscultation, there was saturation was 68%. On doing the clinical anatomy was pulmonary atresia, intact IVS, intact interventricular septum with hypoplasmy. The branch PS size were adequate, and it was a duct-dependent pulmonary circulation, and ventricular function was adequate. We initially shifted the patient to PICU, kept under warmer, and supplemented with oxygen and started on prostaglandin E1 infusion. It was drug dependent circulation, pulmonary circulation. The initial dose was 10 nanogram per kg per minute. And to prevent apnea induced by prostaglandin E1, we started the baby on caffeine loading and maintenance dose. And baseline IV was started according to the unit protocol. And we did investigate for sepsis and the organ function, viral markers, serum analysis, coagulation profile, chest X-ray, and ECG. At this point of time, we had two options. One was ductal stent lab procedure, and another one was neonatal BT shunt in by thoracotomy. As neonatal BT shunt, the outcome is not that good. The outcome is not that good. We went ahead with ductal stenting. This was the echo. This is ascending arch of aorta and just below that we can see pulmonary arteries, and there is a blue flow which is the duct PDA, which is connected. Cursor.
অমিতাভ, এটা স্লাইড শো করে স্লাইডটা চেঞ্জ হচ্ছে না।
Can you see now?
Slide show.
It's here. It is showing. Ductal stenting, neonatal BT shunt. The next slide is this one. The next slide, you can see the aortic aorta and the ductal. Can you see now the vertical duct?
No.
দেখা যাচ্ছে
না, জুমে দেখা যাচ্ছে না। ওটাকে স্টপ শেয়ার করে আপনি
স্টপ শেয়ার করুন।
Can you see now?
Right. ঠিক আছে। Okay.
Fine.
This was the echo showing arch of aorta, and just beneath that pulmonary arteries, and there is a blue flow connecting aorta from pulmonary artery, that is the PDA. And we shifted the patient to cath lab for ductal stenting, intubated and put him on mechanical ventilation, and he had severe subglottic narrowing. So we intubated him and put him, used 2.5 mm ET tube, endotracheal tube. And at this point, we had two approaches available. One was through axillary artery, and one more was through femoral artery. And the orientation of duct was such that axillary artery was preferable. And we accessed axillary artery and accessed PDA with coronary wire. Appropriate stent was deployed. It was 3.5 mm in, and post procedure the position and flow was confirmed with the angiogram. This was the angiogram. This is the stent which we were inflating after keeping the stent in the PDA, across the PDA. Once we deployed the stent, this was the position of the stent across the PDA, and we confirmed the flow through it after doing the descending thoracic artery angiogram. Here we can see the flow through the stent, and that is filling up both the branch pulmonary arteries. and both the lungs. So one more view. Here we can see the stent and flow through it. After the procedure, we shifted the patient to PICU on multiple inotropic support, started him on heparin infusion to maintain the stent flows to avoid the thrombosis, and continued mechanical ventilation for 2 days as we anticipated difficult reintubation, and managed with diuresis as stent flow was increased initially, and monitored with frequent blood gas monitoring, and blood transfusion was given. On day 0 of procedure, he developed left side pneumothorax, for which after consultation with surgical consultants, we kept ICD for 1 day. After that, the pneumothorax was drained. And gradually, patient was extubated on the day 2 of procedure, and rooming in with mother was done along with feeding. And we discharged him on day 15 of admission and day of procedure. The saturation on discharge during discharge was 82%. Starting prostaglandin infusion in all the babies were blue and not responding to oxygen therapy after ruling out respiratory cause, especially at the peripheral sites, very important. And that patient should be referred to cardiac center as soon as possible for further management. And ductal stenting provides crucial bridging time required for the definitive surgical correction later in the life.
Any questions, ma'am? Any questions?
So, my one simple question. Whether you prefer for stenting the axillary?
No, not always, sir. Depending on the orientation of the duct, we will prefer either axillary or femoral approach.
Okay.
Yes. In this case, we preferred axillary approach because the duct was the opening of the mouth of the duct was upwards.
And how long is this? Is it a temporary procedure? Then how long is it expected to last?
Usually at around of 6 months to 1 year of age, we will go ahead with either biventricular repair or single ventricular palliation. Till that time, we will frequently follow up for stent flow and branch PA growth. And after nearly 6 months to 1 year, we will do the definitive surgery.
Can I ask a basic question as a dentist? And can you take me to your first slide? Just the first slide. Okay, it's a very basic question. A baby who's nearly 2 months. How often, and I presume it's a term baby, though it's not mentioned here, but if I assume it's a term nearly 2 month old baby, is it fairly common to have a baby with the duct open?
Yes,
because you stented, you maintain prostaglandin to maintain the patency of a duct,
yes.
a duct that was already open.
Yes.
So my question to you, because you see a lot of reference, so a 2-month-old term baby, is it fairly common to see a patent duct?
Yes, ma'am. Usually, those who are pulmonary atresia condition with the pulmonary circulation is dependent on the PDA. Those patients usually duct closes by 2 to 3 months of age.
They usually come with an open duct.
Yeah, open duct, and we have to start that baby on some prostaglandin infusion. Yeah, usually that closes. Yes, usually it closes by 2 to 3 months of age.
Right. And the second question, you showed beautiful slides of the stenting procedure. Could you kind of tell, okay, you are doing procedures, still hands and things like that. But what are the breakthroughs that can happen in the procedure? It's a very finicky procedure,
Yes,
isn't it?
yes.
So what disasters can befall the doctor and the baby?
One is vascular complications, ma'am.
Sorry?
Vascular
During
complications.
the procedure.
Yeah, during
intra-procedure.
Intra-procedure, there can be vascular complications during access or during catheter manipulation. There may be some dissection in the axillary artery or venous access. And one more thing is, while placing the stent, there can be slippage of the stent, and that can migrate to the other areas. And there can be intra-procedure, the baby can bleed torrentially and go into shock, that we have to manage accordingly. These are the main complications there.
So the last question is rather a difficult question, and I will pose that to you and to your consultant. Given these life-threatening risks, yes, and we always worry about mitigation and the so-called negligence. So how does counseling happen? Because in any, it can slip, it can dissect, it can just wander and migrate off somewhere else. So, in this era of education, how do you protect yourself?
We will counsel the patients, and we'll take high risk consent from the patient. We are explaining all the risk involved in the procedure. And once they give the consent, then only we'll go ahead with the procedure. We'll explain each and everything to the patients, and success rate and our institution success rate and all. We'll explain everything, and then we will go ahead with the procedure.
We usually explain each and everything, ma'am. So it's a very good question you have asked, because especially in the light of the litigations. So what happens is, we explain them that this is a do or die situation. Suppose there are two choices. Obviously, the first choice is do not do anything, which is also a form of treatment. It is also a form, given the socioeconomic condition which we go through. This is not the first and the last operation. The child will need at least another couple of surgeries or interventions. So when we tell them to, suppose a patient who is coming out from very low social, some of them surprisingly tell them, Doctor Sahab, chhod dijiye, isse behtar hai main aur ek bachcha le lunga, which is still practical even in 2022, even in our social conditions which we come through. Obviously, most of these operations are sponsored by the state, but some of the operations are still sponsored by self patients. So they choose to have another baby, and some of them they get discharged. Obviously, they follow up at home. The first question which you asked, yes, it is quite common that we duct-dependent circulations come to us approximately 2 or 3 months old. Still, there may be the duct may be painted. Those who do not come to us, unfortunately, they die at home. So those who surface up, they have still the duct, and obviously, most of them come at the very last stages. We explain to them the horrific situations, each and everything, that obviously it is a life-saving situation, but it is not without dangers and perils, starting from the point of puncture, damaging the arteries, damaging the vessels. The duct can migrate, the duct can stent, the stent can migrate, the stent can be thrombosed, there can be bleeding complications, there can be thrombembolic conditions, and there can be death on the table as well. But given the consequences, we have a parallel surgery, BT shunt, which is also equally problematic, because we divide each and every procedure into 3 stages. Number 1 is the diagnosis. Number 2 is the procedure, whether it is a BT shunt or a ductal stenosis, whatever it is. Number 3, plenty of us do not keep in mind, that is how the baby adapts to the sudden change in the hemodynamics, which show the pathology they see in the ITU, our team looks in the PICU. So there is a drastic sudden change which the baby has to adapt to. And obviously with the diastolic pressures coming low, there will be very low coronary perfusion, the child can have a sudden cardiac arrest. But with practice and all, our team has a good record. In fact, all the teams all over India, now this has become a standard procedure. Given the fact we have a good success rate of almost above 90% in the recent last 3 years. In the initial 2 years, the success rate was slightly low, because that was at that time our team was getting adapted to the procedure.
90%.
Yes. Sir, you were asking something, sir.
Sorry. Whatever he has asked, really, was pneumothorax, accidental pneumothorax, was for accident, was at least we don't use supplement.
We use the axillary artery.
He said 2 months, we don't use the subclavian route.
No, sir, because the margin of safety is slightly less. The supplement would be more. We get the procedure before, just below, outside the ball of the humans, or at least just on the ball of the humans. We try to avoid going medially.
I think what Total is asking is pneumothorax associated
Pneumothorax common in axillary route.
No, sir.
Is it dangerous?
No. It was this child was not. This was independent.
Coincidental.
This was not detected because had it been there, sir, we would have picked it up on the table. We would have picked it up on the table. Thank you, Pratap. The next speaker is Dr. Amnisha Moshi. She is another second year PDT during the DNB Pediatric Cardiology course.
Some questions in the chat box or at some stage just have a look.
Okay, sure. Shonanda visible? Shonanda visible?
Yes, ঠিক আছে স্লাইড শো করুন
We have moved on to slideshow. Can you see the slides?
স্লাইড শো করতে হবে স্লাইড শো হয়নি স্লাইড শো হয়নি এখানে জুমে দেখা যাচ্ছে না আগেরটার মতন
Seen now?
রাইট ঠিক আছে
Good afternoon, my respected audience. So today I'll be presenting an interesting case, pacing the newborn heart and bringing back the rhythm. A case, a term baby born through LSES appropriate for gestational age, died immediately after birth, but had to be shifted to NICU within an hour. There was persistent bradycardia along with decreased activity, and CRT on examination was more than 3 seconds. The baby had to be electively intubated and put on mechanical ventilation. The baby was put on anadrops, but we could not see any response. The heart rate was still persistently low. The other causes of the tube position, everything was checked and confirmed. So what went wrong? We did an ECG, a 12-lead ECG. The ECG showed features of AV dissociation along with persistent bradycardia and fixed RR interval, which is suggestive of a complete heart block. We also did an echocardiography to rule out any structural heart disease. The echocardiography showed the structurally normal heart with a smallish right ventricle, and there was moderate dysfunction. This is a short axis view showing both the ventricles, suggestive of moderate dysfunction. So our diagnosis was a term appropriate for gestational age baby born through LSES, died immediately after birth, but there was congenital complete heart block. We shifted the baby to cath lab and we planned for a temporary pacemaker insertion. We can see a pacemaker lead which we approached through the superior vena cava, entering the RA, and then we targeted to enter the right ventricle. We wanted to place the pacemaker lead in RV free wall cavity. After this, the baby was shifted back to the PICU, but we could see that the heart rate had increased around to 139 beats per minute. We had set the pacemaker to around 120 beats per minute. Saturation was maintaining at around 98%. The invasive arterial blood pressure was showing a mean BP of around 51. But from the ECG trace, we could see that not all the rhythms were getting paced. There was intermittent loss of capture in between. We did a chest X-ray, which showed that there was displacement of the pacemaker lead through the RV free wall below into the diaphragm. The lead did not perforate the diaphragm, but it was below the right ventricular free wall. Since a neonatal heart, there was a smallish RV and the RV wall was very spongy, there was displacement of the lead. That's why all the beats were not getting captured. But the baby remained hemodynamically stable overnight. We set the pacing rate at around 140 per minute, sensitivity to around 10 millivolts. We started the baby on infusion of inotropes, adrenaline and milrinol, and we planned to shift the baby immediately the next day for surgery for permanent pacemaker implantation. In surgery, we kind of fixed epicardial pacing leads in right ventricle. This is the post-pacemaker ECG of the baby, where we can see the pacemaker artifacts in front of each QRS complex. And this was a single chamber pacemaker implantation. You can see all the QRS complexes being paced, and the pacing rate was set at around 150 beats per minute. So around epidemiology of complete heart block, the incidence is around 1:20,000 live births, and the incidence of transplacental exposure to maternal autoantibodies is 60 to 90%. In our case, we kind of took history in the mother where there was any rash, any history of any rash or joint pain, which was negative, and also maternal ANA came out to be negative. Risk in future pregnancies is around 15%. The common etiologies are autoimmune antibodies, structural heart abnormalities like corrected complete transposition of great arteries, endocardial cushion defects, and syndromic ASD. There can be also incidences of idiopathic familial congenital heart block. So presentation in utero, the fetal bradycardia, which can be picked up at around 18 to 28 weeks of gestation. Neonatal presentation can be the baby either can be asymptomatic or heart rate is less than around 100 beats per minute. There can be features of shock and congestive heart failure. In childhood, they generally present with bradycardia with reduced exercise tolerance, history of syncope. So treatment. Treatment of complete heart block in utero treatment with oral corticosteroids is actually controversial and is not advised. Postnatal definitive treatment is pacemaker insertion. So indications of pacemaker insertion. Indications are symptomatic bradycardia, low cardiac output, white QRS complexes, ventricular ectopics or ventricular dysfunction, infants with normal anatomy and a ventricular rate of less than 55 beats per minute, infants with structural heart disease, ventricular rate of 70 beats per minute, less than 70 beats per minute, and children beyond first year of life with an average heart rate of around less than 50 beats per minute. There are two types of pacemakers, a transvenous pacemaker and an epicardial pacemaker. In neonates, we generally prefer epicardial pacemakers since the caliber of the veins are extremely small, so negotiating to the axis will be difficult. And also there's a potential of thoracic growth, so that may cause a tension in the pacemaker leads. So we generally prefer the implantation of epicardial pacemaker, where the are placed in the RV free wall. The preferred approach is transvenous because here we can actually pace the right ventricular septum, which is a more physiological way of pacing. Take-home messages are establishing a temporal correlation between symptoms and bradycardia is important when determining whether permanent pacing is needed or not. Ruling out any reversible cause of bradycardia should be done before considering permanent pacing. Echocardiography is usually the most appropriate initial screening test for structural heart disease, including left ventricular systolic dysfunction. Shared decision making and patient-centered care should be considered for management of such cases.
Okay, Amisha, can I have the first slide, please? Go to the second. Right. So, a very simple question. This is a term newborn who's intensely bradycardic. You have not mentioned it so far any kind of signs of shock, congestive heart failure, and so could you explain to me the reason for electively this way? Because there is no mention on the respiratory status, there is no mention on the hemodynamic status apart from the baby being bradycardic and a CRT which just says less than 4 seconds. So what was the reason for, all hindsight, of course it was a good decision, but what made you think that the baby needed to be electively induced at this stage?
Ma'am, basically, we were thinking of all the differential diagnosis possible. And ma'am, by looking at the newborn, the baby, the heart rate was around 80. It was persistently maintaining at that rate. And also, ma'am, since the CRT was prolonged, there was a thought that came into our mind that it can be due to a case of congenital heart block and it may need a procedure. So just to protect the airway, we had kind of electively intubated the child.
Yeah, so this leads to my second question. So all babies with congenital heart block need to be electively intubated prior to intervention. That is my question.
Ma'am, not all, but in this case, we went ahead with an intubation because we could see that the CRT was getting prolonged, and also, ma'am, there was a bit of deterioration in front of our eyes, so we just went ahead with that intubation.
The other answer is, ma'am, if the operational feasibility, because the baby weighs, most of these babies weigh about 3 to 3.5 kilos. Most of these babies weigh between 3 to 3.5 kilos. So during the pacemaker insertion, if the baby moves, that will be very difficult because the margin of safety is very less. And unless the baby is quiet, and the anesthetist actually helps us, they make the baby quiet, and obviously during these pacemaker insertion, if they move even a bit, there's a high chance that pacemaker lead might just perfectly go. So to make the baby quiet, absolutely quiet with no movements at all, and to see what's happening, we under fluoroscopy guidance, and we also need the babies to be absolutely standstill to make the lines as well. Otherwise, we cannot go inside. That is the reason. That is for the operational feasibility also. We need an intubation.
So can I again ask about what happens in the long run? So baby, so you set the rate at 150, except do you keep decreasing the rate? Number one. Number two is as the child grows, does the lead sort of come out of where it is supposed to be, and does that lead to some intervention further on?
Actually, we kind of follow up, and there is a pacemaker interrogation which happens. So after every monthly, the pacemaker is interrogated, and we kind of see in that whether there is any whether child has its own rhythm or not, and what is the rate of that rhythm, and accordingly we can decrease the rate. And also, ma'am, there has been cases where the child or the patient got back their own rhythm, and where the pacemaker leads had to be explanted or taken out. Yes, ma'am. With growth, ma'am, actually, we kind of see, ma'am, the potential and threshold of the pacing, and accordingly decide.
I mean, the hardware doesn't need to be changed. You know,
No, ma'am. Only the leads.
There are two ways, man. If you're putting an epicardial lead, if you're putting an epicardial lead from outside, there is a little bit of a marginal shift because the leads are usually coiled inside. They are sutured on the artery wall, and there is a margin of safety and the margin which is kept when the child grows, so there will be no tension. So the leads are placed in such a way they are coiled a little bit. But obviously, a child who has had a pacemaker at the age of 1 year, the same pacemaker cannot be running through say until the age of about 10 years. Because before that, the leads will start dislocating. So before that, there is likely that the leads might be changed. There is if you go epicardial. If you go endocardial, there is a transvenous one from the supplemental venous and all. There is a provision that we keep the leads a little bit redundant. Because with age, the heart's axis and the heart's diameters and the length increase, there will be some amount of traction which will fall on the atrial and the ventricular leads. So the atrial lead is kept a little bit redundant inside the ventricular lead is also kept slightly redundant so that there is no absolute tension. They are not placed absolutely on taut. So they are kept a little bit redundant so that with the growth, there is a margin of safety that they are not dislodged just only due to the fact that there is a tension on the cape. They are kept in a coiled. Thank you. The next three cases are from the intensive care. Our intensive care department is headed by Dr. Shubha. Dr. Shubha Jain is our next presenter. Coming back to life thanks to eCPR. The next three presentations are from our pediatric cardiac intensive care unit, which is by Dr. Shubha Das. Shumnanta, slides visible? Shumnanta, slides visible? Shumnanta, slides visible?
না স্ক্রিন শেয়ার হয়নি এখনো স্ক্রিন শেয়ার করতে হবে
Can you see now?
Slide show করুন
Visible?
না স্লাইড শো হয়নি আগেরটা তো হলো
আচ্ছা করছি
আগেরটা তো হলো
হ্যাঁ
না ইটস ওকে ওকে হয়েছে
দেখা যাচ্ছে
হ্যাঁ দেখা যাচ্ছে
Good afternoon, everyone. I'm Dr. Shivangi Jain, and I'm a first-year DNB resident of CTS. I'm here to present a case on eCPR, whereby we will be seeing how eCPR helped a status post Alcapha repair patient come back to life. The patient was a then 3.5-month-old, 4.2 kg female who was referred to our hospital with history of poor feeding and failure to thrive. We did a detailed preoperative echocardiogram and found that there was anomalous left coronary artery from pulmonary artery with moderate MR, severe left ventricular dysfunction, and having an ejection fraction of 10%. There was some evidence of papillary muscle fibrosis as well. The patient was kept in the ICU, managed medically for some time, stabilized optimally, worked up thoroughly, and then taken up for surgery. Intraoperatively, before opening the pericardium, we did a transesophageal echo, which revealed severely dilated left-sided chambers. And also, after opening the pericardium, the same was revealed. We also saw that the left main coronary artery was arising from the right posterior sinus of the pulmonary artery, which is a non-facing sinus. So, in addition to the direct coronary artery transfer technique, which is used for repair, we had to use a pericardial tube extension of the left main ostium as well. The child came off cardiopulmonary bypass with a 0.1 microgram per kg per minute of adrenaline and noradrenaline respectively, and 0.5 microgram per kg per minute of milrinone. Post-operative transesophageal echo revealed that there was severe left ventricular dysfunction with moderate to severe MR. Thereafter, the child was shifted to ITU with chest left open, as is the norms for such cases. In the ITU, the child was found to have weak but palpable fetal pulses. Heart rate was in the range of 150 to 160, having rhythm sinus. The mean arterial pressure was in higher 40s to lower 50s. The central venous pressure was in 8 to 10 centimeters of water. The left atrial pressure was between 12 to 15 centimeters of water. Initial lactate was 6.5. The mixed venous saturation was in 50s. She was started on levosimendan and other inotropic supports were continued. Peritoneal dialysis was also started. The patient remained precariously balanced but stable over the next 24 hours. And again, as is the norm, the chest was closed on post-operative day 1 after assessment, and the child tolerated chest closure well. Inotropic supports were gradually being brought down over the next 24 hours. On echocardiography, the left ventricle was seen to be still moderately dysfunctional. However, the child maintained good markers of cardiac output, as in clearing lactate, increasing mixed venous saturation, having a good urine output. The patient was extubated on post-operative day 3 on NIV, but unfortunately had cardiac arrest soon after. This probably happened in the context of acute rise in the left ventricular end diastolic pressure soon after extubation. Cardiopulmonary resuscitation was started, but without achieving return of spontaneous circulation within 10 minutes. We decided to start her on extracorporeal CPR and cannulated the patient to veno-arterial Ecmo after 70 minutes of total CPR. For the cannulation, we used a 10 French DLP straight cannula for aortic return, a 14 French metal-tipped curved cannula for venous drainage through the right atrium, and a 10 French curved-tipped cannula was placed in the right superior pulmonary vein to LA to vent the left ventricle, and then the skin was closed. This is the picture of the child cannulated on ECMO and the X-ray chest showing the aortic cannula, the venous cannula, and the LA vent in situ. Initial ECMO settings were as follows: flow 100 ml per kg per minute, sweep gas was 0.5 liters per minute, target ACT was 180 to 220, rest settings on ventilator were pressure control mode 20/10, respiratory rate 15 per minute, neutral inspiratory time 0.8 seconds, and FiO2 of 0.4. The child was sedated with dexmedetomidine and morphine and paralyzed as and when needed. And empirically was given a cover of piperacillin, tazobactam, and teicoplanin, and cultures were sent. During the entire ECMO run, hemodynamic parameters and end organ functions remained stable, and the child showed gradual improvement also there was in the left ventricular function as seen in this echo. Daily assessment of suitability to wean was done. The child was supported on ECMO for 72 hours 45 minutes, and she was decannulated, and then chest was closed. After 2 days, we extubated her on an IV as this picture. Her neurological parameters were normal thereafter. Over the next week in ICU, the left ventricle function showed gradual improvement as seen in this echo. This was a field discharge echo that we did for the child, and the respiratory support was also gradually weaned off. Finally, we were able to discharge her in stable condition on post-operative day 14. So just a brief description of what is eCPR. It is a rapid deployment of veno-arterial extracorporeal membrane oxygenation or cardiopulmonary bypass to provide reperfusion with oxygenation and cardiovascular support in the context of cardiopulmonary arrest. And in the past decade, there has been increasing use of eCPR because of data availability of better survival with use of eCPR. There was paucity of data regarding the exact timing and indication of initiating eCPR, which it was mostly institution and experience driven. In 2018, the Extracorporeal Life Support Organization guidelines, it clarified the definition for eCPR. So eCPR is now defined as when ECMO flow is instituted using conventional CPR delivered with manual or mechanical compressions or within 20 minutes of return of spontaneous circulation without ongoing compressions. As such, as we said in the previous slide, that eCPR is defined in the last part we discussed that it is defined as within 20 minutes of return of spontaneous circulation without ongoing compression. So patients cannulated after 20 minutes of sustained or return of spontaneous circulation, that would not be classified as eCPR, that would be called as VA ECMO. Now there's data supporting the fact that eCPR leads to better preservation of cerebral circulation as against conventional CPR. A 2016 study demonstrated improved survival and neurological outcome in children who suffered in-hospital cardiac arrest more than 10 minutes and underwent eCPR as against those who underwent conventional CPR. eCPR and cardiac indications now account for about 50% of the ECMO cannulations. The American Heart Association also considers eCPR now as a reasonable intervention in those pediatric populations who undergo in-hospital cardiac arrest and also have an underlying cardiac disorder. I would like to show you an also data of July 2020, in which we can see that out of around 5,000 patients who underwent CPR, 52% survived ECLS and 49% showed survival to discharge or transfer. So what is ELSO? It is basically a non-profitable organization that was established in 1989. And it supports healthcare professionals and scientists who are involved in extracorporeal membrane oxygenation. It maintains a registry of both facilities and specialists trained to provide ECMO services. NSH Howrah is also an ELSO recognized, ELSO registered Ecmo Center. So this case was covered by a local daily, this having been an uncommon case which we could successfully publish. So this was covered by your local daily. With your permission, I would like to call upon the patient now.
She's 7 months old now.
She's 7.
And neurologically, so far, she's intact as per my assessment. She's rolling over, she's babbling, she sits with support. She's Maisha Chaudhary, who suffered.
She's actually posing. And it was not only I'm negotiation. It was not only parents who were like us who underwent through this stress, they were part of that journey as well. Intensely stressful. Al-Kappa, as you all know, is a very rare but we do encounter, say, 4 to 5 a year by virtue of somebody else doing those cases. But in this particular case, most of them will have ventricles like this because ventricle has never received any oxygen in the past. So they will have ejection fraction ranging from 20 to 10% in most of the cases. And that is why we had initially thought that we probably will not be separate from ECMO as a standard. But at that point of time, hemodynamics dictated that we were probably okay with just anaerobe, so we did not initiate ECMO at that stage. First,
your access was already.
no. So, and then next day, the child was okay, so we even closed the test. As is the norm in such cases, just already close it in the ICU itself the next day, which is what we did. And then we progressed further to extubation. This was a completely unanticipated. That is why, rather than Al-Kappa and the nitty-gritties of it, we wanted to concentrate on the salvage of the baby by. So I was actually operating inside the operating theater on a different case when they started CPR. Should we plan into the said that it is arrested because we had arranged it. Should we just go? And so I kind of peeled myself off, and then the other somehow reopened the chest. The chest was also closed. continue to massage, and this is like a 480 cannula spine massage, and then shaded it off. The total duration of the entire thing that we would reasonably machine assisted cardiac output was around 45 minutes.
Yeah. But then the initial part of CPR was like around 10-15 minutes, so in together it's to like 70 minutes. So this is an established form of ECMO support in established ECMO centers in the Western world. This is what this is actually what is done in such scenarios. That in institute DCPR, in unanticipated cardiac arrest, in hospital cardiac arrest, there is no return of spontaneous circulation. So there is a team, there is always a machine primed and ready to go. But of course, in our scenario, it's not the case. One, there are logistic issues like an ECMO entire like the circuit costs around 2.5 lakhs. So just priming it and keeping it ready to go for ECPR, that's probably we won't reach that stage, or we are not yet at that point. So we had the machine outside, but yet not primed, and it still takes a lot of time, to prime. Even if you prime with crystalloids, that also takes a lot of time to set up the machine. Now the perfusion is they have to peel off from surgery, come here, so it takes a lot of time. So it's more so challenging for us. But I think as we do more and more ECPR, we did several ECPRs when we were training outside, but now as we have started here, as we do kind of more ECPRs, we'll gradually reach there to initiate the ECPR within a lesser time, or within a reasonable time. 70 minutes to start a patient on ECPR is probably a little bit.
And it's just that neurological injury.
Did your first case?
Not the first ECMO case, but first ECPR.
There was a slide, 5,000
No, that was according to the ELSO data.
That
This was the ELSO data on July.
That is the number of ECPR performed in the world so far.
Worldwide.
So there are also registered like 150 or something centers.
And this is including adults.
What your training program?
On this ECPR, Canada and UK. Canada and UK.
A basic question for my understanding. What makes the person on the spot decide in the case of in-hospital cardiac arrest with underlying cardiac disorders that I'll go for ECPR, maybe salvageable, or I will not go? Of course, she has mentioned there are stringent guidelines, but you're there on the spot. So this baby's had cardiac arrest, the baby has an underlying defect.
Many times it's your clinical decision. One of the things about ECMO, not only ECPR or any ECMO, even elective ECMO, you have to ask yourself that what is my exit strategy? It's very easy to put on a machine, even like ventilator, but how will I come out of it? Because that's going to be like an antibiotic. But it's just going to give you time. So if you think that this is probably a reversible cause, and this is something where everything was going smoothly, and this is a sudden arrest, and still I have chances to stage the patient. The patient have the other functions, the other organs are working fine, including the heart, the brain, the kidney. So I know that this heart just needs time, because we knew even before extubation that this cardiac function was poor, but the operation has been done. So with time, with good, now the heart is receiving good oxygen supply. This will go, but will need time. So if you see like the echocardiography, which was just done before extubation, the cardiac function was poor. So this was unexpected. I would say not completely unanticipated, because if you think about your cardiopulmonary interactions, as soon as you take off positive pressure, it creates a huge upper load on your left ventricle. So I think that's what happened. There was an acute rise in LVET, and that this was not going to come back. This was not going to come back even if we do ECPR. The child would keep on having this arrest again and again. So that's when we decided that let's give the child some time. Let's candidate her to on ECMO, and then let's see what happens.
So, in an ideal world, post cardiology, every patient who has an unanticipated arrest is a candidate for ECMO if it is reversible. So that is the so in an ideal, that's how the cardiac ICUs outside will actually have an ECMO machine there, or some form of contact. On institute, you would actually keep a cardiopulmonary bypass machine for the want of a better machine, just because it is cheaper. But there are major sort of financial logistic concerns here. So in an ideal world, as long as we know that this condition is reversible, most of these ECPR segments are post-cardiology patients. They've all undergone some form of cardiac surgery. Now, it might be a situation that surgically we think that this patient is not a reversible cancer. That is when you would probably hold yourself and don't initiate. Otherwise, every candidate for reversible cardiac.
And if you started in PCR and if there is no response, what is the time?
Ma'am, you can actually
And do you continue your search?
no. Yes, because what would happen is the moment the heart rhythm has to be right, so it has to beat. Most of the cases, once you decompress the heart, once the heart doesn't have to support your circulation, the rhythm comes back. Sometimes you might have breaks, but you will have to have the heart beating. It is only maintaining itself. The amount of coronary perfusion that it takes is the only oxygen required. It is not supporting your circulation. So you can actually support it for 45 days, 30 days, one longer. But yes, but within best outcomes are when you are able to decline the more the duration is, chances of neurological bleeding, having neurological sequel of sort of subtle brain damage or even overt brain damage is higher. That is one of the main
Our next presenter is Dr. Unmesh. He is also one of our cardiac surgery trainees, and he is going to present his case on perils of primary fontan failure and ICU nightmare. What shall I do? Just open this and take it.
You first clear the screen.
You escape from out of the screen first. Escape.
স্লাইড শোটা করতে হবে, স্লাইড শো।
আচ্ছা, এইটাকে আগে অন্য স্লাইডটা এখন আমরা দেখতে পাচ্ছি, ওটাকে তাহলে স্টপ শেয়ারিং করে আবার নতুন করে শেয়ার করি।
হ্যাঁ হ্যাঁ, স্টপ শেয়ার করে দেবো,
আমি করে দিচ্ছি। হয়ে গেছে স্টপ শেয়ার। এবারে আমাদের
এবার শেয়ার স্ক্রিন করে
হ্যাঁ হ্যাঁ না দেখা যাবে, দেখা যাচ্ছে
এখনো আসেনি, লোড হচ্ছে। এবারে স্লাইড শো করে দিন। স্লাইড শো হয়নি, স্লাইড শো হয়নি, জুমে দেখা যাচ্ছে না স্লাইড শো।
স্লাইড শো করে দিয়েছে, কিন্তু স্লাইড শো বাটনটা আমি
জুমেতে স্লাইড শো দেখা যাচ্ছে,
এমনি স্লাইড গুলো দেখা যাচ্ছে কি?
স্লাইড দেখা যাচ্ছে। নেক্সট স্লাইডে গেলে স্লাইড চেঞ্জ হবে না, আপনি নেক্সট স্লাইডে যান, নেক্সট স্লাইডে যান।
নেক্সট স্লাইড
না, এটা স্লাইড চেঞ্জ হচ্ছে না, হবে না। এবার ঠিক আছে, থাক, এই থাক, থাক থাক,
ঠিক আছে,
স্লাইড হবে, থাক।
ঠিক আছে। First slide.
Hello. It's a bit of lag. I apologize for the technical challenges. Good afternoon, everyone. I am Dr. Unmesh Chakraborty, CTPS training at NSC Howrah. I'll be presenting on the perils of acute fontan failure. My case is a 6-year-old female child weighing 31 kilos who was diagnosed as a case of tricuspid atresia 1B She underwent cath and fulfilled all our criteria for a primary Fontaine completion surgery. Before surgery, she had one large major aortopulmonary collateral artery which was coiled, and she underwent extracardiac Fontaine completion as the
Slide is not changing.
Slide is not changing.
The slide to change coding. This is the first slide.
Is it okay? Is it okay?
It's okay.
Okay. Apologize for the technical challenges. So she underwent extracardiac Fontaine completion surgery as shown in this image. 18 millimeters cortex graft. The surgery was pretty uneventful, but the major story started later on when she was shifted back to the ITU. So she developed all features of low cardiac output state. Her lactate levels in the ABG was off the charts. She had features of metabolic acidosis. The mixed venous saturation was low. There was a wide AVO to saturation difference, and mean arterial blood pressure was also low in spite of giving quite a lot of fluid boluses and keeping her on high inotropes. She had a narrow pulse pressure and her urine output was also gradually decreasing, and there was a significant core to periphery temperature difference. Not showing up. Yeah. এটা এখানে চেঞ্জ হচ্ছে স্লাইড শো slide show. Okay, so I'll continue. Her gland pressure was in the mid tens. Yeah. So the gland pressure with the cannula in the interjugular vein was in the mid tens, but the femoral line CVP had a reading of around 30s. We did a echocardiography which showed dilated IVC, and the respiratory variation was also quite sluggish. We confirmed it with the agitated saline test, and the echo also showed some degrees of ventricular dysfunction. Our major suspicion was there was some problem in the Fontaine circuit, and the lower part of the body was probably not draining well. So we planned for a Fontaine takedown, and all of this happened within 5 to 6 hours of shifting her back to the ICU. So she underwent a Fontaine takedown where the IVC end was divided and closed at the right pulmonary artery, and it was routed back to the right atrium. We found some small clots in the IVC end of the conduit, but it's still debatable whether that was the result of a sluggish flow or it was a primary cause of Fontaine failure. So as shown in literature, Fontaine failure might be due to several factors like high pulmonary vascular resistance, then low cardiac output, some arrhythmia, thrombosis, ventricular dysfunction, and obstruction of the pulmonary veins or artery. And acute Fontaine failure, which happens within 1 month of the surgery, it is a very rare entity, and its incidence is around 1 to 3%. This is a flowchart from a case series published by Christian Armand in the Children's Hospital, Boston, which showed that 45% of patients died in the immediate perioperative period following Fontaine takedown. We can see out of 53, 24 patients died in the immediate perioperative period. And those of who survived, they also had a large number of morbidity like persistent ventricular dysfunction and intractable pleural effusions at times. So after the Fontaine takedown, the child had better hemodynamics. The lactate was initially high, more than 15, but it cleared out over the next few days. mixed venous saturation and AVO2 difference was rectified. Urine output was around 2 to 2.5 ml per kg per hour. Echocardiography also showed some improvement in the ventricular function. IVC respiratory variation was also better. Blood pressure remained around 18 to 19, and we could gradually we extubated her on second POD electively to humidified high flow nasal cannula, and we could wean off the child from inotropes over the next 72 hours or so. But our main challenge, and we faced the roadblock here, was end organ dysfunction, and LFT showed the AST levels were in mid 10,000s, and bilirubin rose to 20. The major component of that was a direct bilirubin. INR was also raised around 3 to 3.5, and there was no overt bleeding or encephalopathic features. Her urine output consistently remained stable, but her urea was in the 130-140s range, and creatinine was around 3. So she had features of non-oliguric AKI. She was started on N-acetylcysteine, and peritoneal dialysis was also done. We sent a fractional excretion of urea, which also came out to be high. Gradually, her liver enzymes improved over the next 7 days. Albumin was as usual normal, but features of AKI and severe conjugated hyperbilirubinemia persisted. So we sought an opinion of our nephrologist. We discussed whether there could be a component of bile pigment nephropathy. So we did a USG KUB, and the findings were essentially normal. Renal biopsy was considered, but in the setting of high INR, we definitely could not perform it. Urine showed some growth of E. coli, but she was started on appropriate antibiotics, and she responded well to that. We decided to start hemoperfusion for removal of bilirubin. So as you can see in the picture, these are two separate dialysis machines, one used for plasma separator and another for the heme adsorption using a BS330 cartridge. Prior to that, 12 French gas cath was inserted, and the child underwent one cycle of heme adsorption. Post hemoperfusion, the total bilirubin decreased to 12.2 from 24.3, and the direct component was 10.7 from 22.5. Urea fell to 44 from 145, and creatinine decreased to 1.1 from 3.77. So all of these are quite significant changes. We can see the trend of the liver function test in the picture on the left. We can see the direct total bilirubin and the direct bilirubin all sliding downwards after hemoperfusion. Same with the ACALT levels also. And with the urea and creatinine, which was like the urea was 145, but after hemoperfusion, it gradually came down. And when she was discharged on POD 21, it was around 23. Same with the creatinine, it was 3.77, and gradually it came down to around 1.86. Still, she had some features of fluid overload and pleural effusion, and she underwent 3 cycles of hemodialysis. She tolerated the procedures well. Her hemodynamics were all stable. We discharged the child, but before that, we had planned to keep her on peritoneal dialysis. So we inserted a 16 French tank of tunnel catheter, and for purpose of continuous ambulatory peritoneal dialysis. The child was discharged on 21st POD in a hemodynamically stable state, and her discharge creatinine, as I've shown before, was 1.86. Post-discharge, she underwent thrice weekly sessions of CABD for the next 3 weeks. And when she came back on the 42nd POD on follow-up, her numbers were like this: urea 21, creatinine 0.4, total bilirubin of 2.8, direct of 2.27.
Slide not changing, sir.
Sorry?
Slide not changing.
It's not changing. Sir, I'm reading out. So renal injury, mostly acute tubular necrosis, has been shown to be associated with acute liver failure, and bile cast nephropathy has been a cause in such cases. The mechanism, it can be due to a lot of factors, but tubular epithelial injury, basement membrane defects, then tubular leakage and obstruction as a result of being overflooded with bile cast, they have all been shown to contribute to this. Excess bilirubin also has some negative inotropic and chronotropic effects as shown in some studies. In a literature review by El Shadiak et al., it was shown that there are no current specific treatment guidelines for bile nephropathy. Yes, if there are some obstructive lesions, we can definitely go ahead with ERCP plus minus stenting, depending on the case. But medical therapy like UDCA, cholestyramine, steroids, they have also been shown to give no additional benefit. Extracorporeal therapies such as this one have been proven to be effective. Biologic therapy using human and porcine cells for detoxification, as well as non-biologic therapy using artificial membranes and adsorbents have also been shown to be effective. Plasmapheresis has also been shown to remove excess toxins and bilirubin and also replenish albumin levels, coagulation factors. Heme adsorption in a few studies has been shown to significantly reduce hyperbilirubinemia, and a few other studies have also published favorable results using plasma exchange. All in all, these studies show good signs, but there is definitely a need for large-scale studies to gather more data on the outcome of this therapy for this. I'll conclude my presentation by saying that reaching a pinpoint diagnosis of bile cast nephropathy in this scenario where you cannot do a renal biopsy or even a transjugular biopsy in a patient whose INR is so high, then if a clear-cut cause is not identified, then the suspicion and definitely a subsequent prompt treatment for this entity should be considered and start. Thank you. And similarly, I'd like to, with your permission, I'd like to call upon the patient and his parents are over here.
She has come for follow-up. She is getting readmitted today.
Yes.
We will take out the catheter tomorrow and hopefully discharge on Saturday.
This is Shani.
If I may, I'll just give a background of what Fontaine circulation is. Basically, before 1960, single ventricle patient, there was no treatment. They would just have their natural. That's when Francis Fontaine actually thought that right ventricle is probably a ventricle that we can get rid of without any issues because your CVT or your venous pressure is sufficient to drive your pulmonary blood. So it is usually done in a stage manner. First stage is a cleanse, then connect your SBC to your pulmonary circulation. And that CVT is enough because the only presumption is your PVR has to be normal. And there should not be any distortion of the anatomy of the pulmonary vasculature. So that's the structure. Because there's no driving force, there's no pump driving. But that idea itself was revolutionary. It actually sort of survived without one ventricle. And once these patients are around 3 to 4 years of age, so that only SBC blood going into the pulmonary vasculature not have sufficient saturation have sufficient. That is when the Fontaine circulation will be completed. Meaning you connect to the IVC on pulmonary vasculature. So now your entire venous system is directly going into your pulmonary vasculature without going into the heart. Now there are various modifications, and currently what we do is known as cardiac. So we put a pipe from the IVC, the graft, pulmonary vasculature straight away as a stage. So first we do sort of within 1 year of age, we would put a cleanse. And then we would complete the Fontaine by around 5 years. Sometimes when patients like this present to us late, so she hasn't had a cleanse, and these are the patients in which when our cardiology colleagues are confident that the PVR is all okay, and this patient can have a single stage. She will have the Glen and the Fontaine together at once. We have done few of them here. It's not a very commonly done procedure, but those are the patients who at some times might have a thing like an acute Fontaine, which is a very catastrophic, as you all saw. It does not. So this patient had a documented normal PVR. There was no reason for it, and there was nothing sort of mechanically obstructing the graft. So the body was had done the procedure. And by around sort of early evening, we were sort of sure that there's something wrong. So we cannot make it. That is when we decided to take the patient back and convert it back to a gland, which itself is a big undertaking. That paper which he was showing is actually from Boston, which is one of the largest series of acute coronary failure data, has a 50% mortality. So it's a very catastrophic situation to deal with, and the decision to undo the contact is not a very easy one. But because of sort of our sort of yes, so that is why we were pushed to the corner and we undid it. But those 6 hours of this suboptimal circulation resulted in entire splanchnic circulation not flowing. So the venous pressure in the splanchnic circulation was super high during this. That is why we think that the liver, kidneys were the main 2 organs which had suffered significantly because it was a venous obstruction. Another, sometimes the gut suffers. Those are the patients with cancer. Gut also has an ischemic component.
This is something like you are completely occluding your IVC, like good 6 hours, and there is no venous drainage happening from. Yes, very severe, because you have blood going inside the organs but not coming out. So super high pressures. Yes, for 6 hours. So that can. Yes. Yeah, so that kind of.
Acute liver failure and you had
Yes, yes.
So for acute liver failure, you took hemoperfusion.
So this was, ma'am, like 3 to 4 days down the line that things were not improving and this conjugated hyperbilirubinemia was persistent, and we were sure that that the liver, like another substrate is the liver enzymes coming down, but the bilirubin remaining high. So that can be also signify that the liver is extensively damaged. But it was not like that. Albumin was normal. Your INR was gradually coming down, but it was just conjugated hyperbilirubinemia.
You just wanted to remove them.
Yes.
So I understand what you did for the. And then for renal support, you continued dialysis.
So peritoneal dialysis was started from. Yes.
First chemo and then.
No, peritoneal dialysis was started on POD1. That's generally a norm in very sick cardiac patients. That's what we would do. And then gradually, once we were reaching like almost 2 weeks down the line, 2 weeks of POD, then we decided to do some hemodialysis as well, because the VASCAT was already in, the patient was off inotropes, the patient had some pleural effusion. So we thought, why not, make him try. Yes. So that's when we did 3 cycles of hemodialysis. But again, once she was, and then we decided that we will, because the urine passage was adequate, like around 1.5 to 2 ml per kilo, we said that we thought that we would just give her some time of peritoneal dialysis, not do any HD, see for a few days what happens to the urea and creatinine and the electrolytes. Electrolytes remain stable, but again the creatinine started to rise, urea started to rise a little bit. Then we decided that we will change her to a 10-cuff catheter, and she is hemodynamically stable. We will discharge her, teach the parents, and also coordinator, like liaise with them.
What you said, the CAPD treatment, that is very unusual.
No, this was like what our nephrology department generally does. They liaise a CAPD coordinator with the family. So that person goes there at home and does this. So while at the hospital, she was of course getting the normal peritoneal dialysis cycles, but at home, that's what she was getting. And she got this for like 3 weeks, then came back with all these normal reports. And now we will remove the 10-cuff catheter.
So not CAPD, then a few cycles.
Few cycles, you could say. Yeah. Yes.
It's not.
Okay. So our next presenter, I would like to call up on stage, is Dr. Manisha Roy. We also have a general PICU other than the cardiac ICU here. So she is one of our medical officers, very bright medical officers in PICU. And she's going to present a case on tumor syndrome. This would be called severe tumor lysis syndrome, saving a sinking ship.
They're really running very late, so we have to speed up a bit. Last 2 cases. Okay. There is one more, no?
I'm just slide.
Share screen করে slide show করতে হবে।
আমি বলছি
Good afternoon, everyone. I am Dr. Manisha Roy, PICU medical officer, and today I'll be presenting a case of severe tumor lysis syndrome.
First, you share the screen.
Slide.
Dr. Roy, first you share the screen.
Yes.
শেয়ার স্ক্রিন তো করে শেয়ার স্ক্রিনে সে আমি তো বুঝতে পারছি share screen is on.
No. Now just loading. Now it's loading.
Can you see?
Yeah.
Can you see?
Yes. New slide show. Go in slide show.
Slide show mode.
Slide show না হলে আপনার স্ক্রিন শেয়ার নেক্সট স্ক্রিনে যাবে না, নেক্সট স্লাইডে যাবে না।
এখন স্লাইড শো হয়ে গেছে তো
আপনার হচ্ছে না, না এখন হচ্ছে না ঠিক মতন স্লাইড শো মেক দিন।
স্লাইডটা দেখতে পাচ্ছেন?
আচ্ছা আমি আবার শেয়ার করছি।
স্লাইডটা দেখা যাচ্ছে?
স্লাইড দেখা যাচ্ছে দিদি, কিন্তু নেক্সট স্ক্রিনে যাচ্ছে না, নেক্সট স্লাইডে যাচ্ছে না, একটা জায়গায়
এখনো যাইনি তো আমরা নেক্সট স্লাইড।
আচ্ছা একবার নেক্সট স্লাইড ট্রাই করে দেখো যায় কিনা।
যাবে না, স্লাইড শোনা হলে যাবে না, ওটা ম্যানুয়ালি করতে হবে, ম্যানুয়ালি করতে হবে।
এখন যাচ্ছে?
হ্যাঁ তো
ম্যানুয়ালি করে দেবো, ম্যানুয়ালি করে দেবো। লাস্ট
এটা কি লাস্ট কেস?
মোস্টলি লাস্ট।
না এটা কি লাস্ট কেস?
এরপরে আরেকটা আছে। So who is presenting? You are presenting the last case, okay? Slide. এখান থেকে যা আছে স্লাইড শো। হ্যাঁ কি আসছে
স্যার স্লাইডগুলো এখানে আসছে।
সেটাই হচ্ছে, সেটাই হচ্ছে আসবে তাই এটাতে তাকিয়ে বলবো। আচ্ছা কি ল্যাপটপ
এটা তো ডক্টর চ্যাটার্জির ল্যাপটপ, ডক্টর চ্যাটার্জি নেই ওখানে?
এই তো এখানে হচ্ছে, ওখানে হচ্ছে না না উনি এখানে নেই। এখান থেকে
আগের গুলো তো উনি করে দিয়ে গেলেন।
এবার দেখুন তো
না
স্লাইড শো হয়েছে
না, আপনি একটা কাজ করুন তো, আপনি স্টপ শেয়ার করুন। এবারে স্লাইড শোতে গিয়ে তলায় দেখুন একটা ছোট্ট আইকন রয়েছে, ওটাকে ক্লিক করুন তো। শেয়ার স্ক্রিন করলে একটা ছোট্ট আইকন পাবেন একটা নিচে শেয়ার স্ক্রিনের পরেতেই। মিউট হয়ে গেছে, শুনতে পাচ্ছি না।
এবারে আমি এখানে শেয়ার স্ক্রিন করে আমি এটা কয়েকবার
আগে ক্লিকটা করেছেন, সেখানে একটা টিক দিতে করা হয়েছে কি শেয়ার স্ক্রিনেতে গিয়ে একদম তলার রাইটে একটা টিক দিতে হবে, একটা বক্স আছে ছোট্ট, ওটাকে সিলেক্ট করুন।
কোন বক্সটা?
শেয়ার স্ক্রিন গেলে সামনে একটা তো বক্স মতন আসে,
হ্যাঁ
আপনি এটা দেখতে পাবেন, তার একদম সেই বক্সের লাইনের একদম লেফট রাইট হ্যান্ডের বা লেফট হ্যান্ডের একটা ছোট্ট একটা আছে।
আচ্ছা
সাউন্ড শেয়ার বা কিছু শেয়ার বলে কিছু লেখা। এবারে স্লাইড শো করুন।
হয়েছে স্লাইড শো?
ও আপনাদের ল্যাপটপে কিছু অসুবিধা হচ্ছে, এটা ডক্টর চ্যাটার্জি পারবেন, ডক্টর চ্যাটার্জি করে গেলেন ফার্স্টে দুটো তিনটে।
যাই হোক আমরা
কাজ করে এমনি ম্যানুয়ালি স্লাইড শো না করে ম্যানুয়ালি পরপর পেজ ডাউন দিয়ে স্ক্রিন মানে পেজ ডাউন দিয়ে দেখি। স্লাইড শো করার দরকার নেই, পেজ ডাউন দিয়ে স্লাইডে গিয়ে নেক্সট স্লাইডে গিয়ে বলে দিন।
হ্যাঁ इसमें चेंज होगा ना, इसमें चेंज ये उससे चेंज हो रहा है। इसको निकालो, इतना से क्यों आता है? এটাকে একবার এখন ঘটিয়ে পড়।
আমরা তো কজনই আছি, সো যদি এখানে জুম আসে আমরা কম্পিউটারটা টার্ন অ্যারাউন্ড করে আমরা
তাই কর। ঠিক আছে, एक मिनट लास्ट एक मिनट देखते हैं। इधर से छोड़े display the slide show, just छोड़ दो, बेकार में टाइम एक सेकंड। हाँ ये तो ठीक है, सेव करो। ठीक है, स्लाइड है।
Today I'll be talking about severe tumor lysis syndrome. There was a patient, 1-year-old boy, 8.5 kg, and he was referred from Bokaro to our NSH PICU. He had history of fever, gradually turning pale and not feeling well for the last 3 weeks. At presentation, he had moderately increased work of breathing with some stridor and with oxygen saturation of more than 95% with 2 liter per minute in nasal cannula oxygen. He had generalized lymphadenopathy, gross hepatomegaly, and pallor. He had no bleeding manifestations. Chest X-ray showed widening of superior mediastinum. Echocardiography showed a structurally normal heart. With good biventricular function, no pericardial effusion, and no obstruction of outflow tracts. These are his blood work. Hemoglobin was 8.5 gram%. Total count of 3,44,600 per microliters. Neutrophil of 0.9%. Lymphocytes of 97.3%. Platelets of 57,000 per microliters. Potassium was 2.5. Sodium 136. Calcium 11.4 mg/%, phosphate of 2.9 mg/%, uric acid of 21.9 mg/%, CRP of 63 mg/L. Serum creatinine was 2.35 mg/%, blood urea nitrogen of 18.69 mg/%, LDH of 2,799 units per liter, LFT and coagulation profile was otherwise normal. The child was put on high flow oxygen at the rate of 2 liter per kg per minute and 0.5 FiO2. Central line was inserted an internal jugular vein, and he was initially started on hyperhydration. Initial gas from the CVL showed mild metabolic acidosis with pH 7.29. Lactate was 1.4. Mixed venous saturation 65%. He had good pedal pulses. Heart rate in 120s and NIBP of 100/58 mm of mercury. Intravenous fluid was started initially at 150% maintenance fluid with bicarbonate as necessary. He was started on allopurinol, piperacillin, tazobactam, and ofloxacin. Gases and electrolytes were done every 4 hours. Our target pH was 7.4 to 7.5. CBC was done every 12 hourly. For the first 12 hours, he remained clinically stable on high flow, maintained urine output of 2 to 3 ml per kg per hour. A bone marrow aspiration and biopsy were done under conscious sedation, and immunophenotyping was sent. Above were suggestive of T-cell acute lymphoblastic leukemia. He was put on BFM 2002 chemotherapy protocol, that is pre-induction with dexamethasone 12 mg per meter square per day. Over the next 8 hours, the total count reduced significantly from close 350,000 to 28,400. The child developed significant hyperphosphatemia with values 17.2 milligram percent and hypocalcemia of 4.3 milligram percent, along with tetanic spasm of hand muscles. Potassium was 5.4. Hyperuricemia persisted despite giving allopurinol in reasonable dose and increased up to 22.7. Creatinine hovered around 2 to 2.5 milligram percent. Intravenous fluid was increased to 180% maintenance. Earlier it was 150. He was started on sevelamer and calcium infusion. Diuretics were tried. 1 dose of resburic was given. Uric acid reduced over the next 3 hours to 2.9 milligram percent and continued the decreasing trend, as we can see on the graph. Just after that administration of resburic, we can significantly see uric acid decreasing trend. Hyperphosphatemia, however, persisted. Over the next few hours, he became very irritable. Urine output dropped to 1 to 1.5 ml per kg per hour. His work of breathing significantly increased. Lung USG showed features of pulmonary edema, V9, as we can see in the picture. In the presence of large mediastinal mass, we decided to try NIV at this point rather than endotracheal intubation, which could be fatal in the current circumstances. He was sedated with dexmedetomidine while on NIV. Infusion was started. He was in tumor lysis syndrome, and clearly the strategies adopted so far were not working. There were discussions about starting peritoneal dialysis. However, was decided against due to very large hepatomegaly, almost occupying the entire abdomen. We decided to start hemodialysis. 10 French basket was inserted. FX-back dialyzer was used. Surface area of 0.2 meters square, while the body surface area of the child was 0.38 meters square. We can see the picture of the child on NIV undergoing hemodialysis. 3 cycles of hemodialysis were given over 3 days. Smidge of noradrenaline was started in the background, but he overall tolerated the procedure well. We can see the blood parameters which improved over next 3 days. Phosphate was 2.3 milligram percent, calcium 9 milligram percent, potassium 3 millimoles per liter, creatinine of 0.454 milligram percent, total count 4,600 per microliters, then reduced further to 1,800 per microliter. Urine output improved to 2 to 3 ml per kg per hour. We can see in the graph change in phosphate with total leukocyte count after starting hemodialysis and change in phosphate with time. Now we can see lung USG showed normal parenchyma A lines and mediastinal widening on chest X-ray also remarkably improved. We were able to wean the child off NIV onto high flow and gradually to nasal cannula oxygen in the next 2 days. Noradrenaline was weaned off and he was shifted to hematology ward for further continuation of treatment of leukemia. This is his immunophenotyping report, in which the findings are consistent with T lymphoblastic leukemia. Now, what is tumor lysis syndrome? It is an oncology.
Just for the case.
Okay, sir. Okay, ma'am.
Very, very well managed.
Thank you, ma'am.
I think very well presented and very well managed. It's something that a lot of people have left. One or two questions for us? You know, again, a very basic question. At the very beginning of the story, did you all have a clue as to what was going on with this child? Before you got the biopsy report and things like that. No, you had this, all haywire, you had a town like that, a CRP like that, it was just all over the place. So, what was the reason for referral to NSH PIC from Bokaro? Why did they refer this patient from Bokaro to NSH PIC? That's one question. And number two, had you any clue before the reports came through as to what you were dealing with?
Thank you for the question, ma'am.
The recapitulation was like that.
That's it.
But you had a count of 3 lakhs on 3 lakhs. Yes. A grossly high CRP, all your multi-system range. Yes. So, why did the child travel from Bokaro to NSH Howrah? Number one. Did they have a clue as to what they were dealing with? What was the reason for referral? And number two, did you all have think about a tumor lysis before things started pouring in?
First of all, we did not think about tumor lysis, but after doing all the blood works, it significantly showed. After doing the blood works, we saw there is a rise in uric acid, plus there were rise in calcium, decrease in calcium with increase in potassium and increase in phosphate levels, which in definition of tumor lysis syndrome we can.
So why was the child breastfeeding?
Can I answer on her behalf?
I was just giving her a hard time because she presented well. That is the only reason. Because this question obviously I would have put forth to your consultant, but because you have presented so well, so that is the reason I put these two nasty questions to you.
Have you got any input that percentage of tumor lysis syndrome? Any percentage or any? There is any data.
So yes, there is a data. She was about to present this in her discussion. We had a nice slide on that. But around 17% of the patients with T-cell acute lymphoblastic leukemia, they can present with tumor lysis syndrome. If we look into
what's the percentage?
17. And if we look into the definitions, Cairo Bishop definition, as they say, there are two criteria. There are two definitions actually. One is laboratory tumor lysis syndrome, one is clinical tumor lysis syndrome. Initially, with the clinical features, our patient figured in the definition of laboratory tumor lysis syndrome. But then when the creatinine also went high and then he started to have tetanic spasm, at that point of time, he was having clinical tumor lysis syndrome. There are two papers, one from Boston children, another from Job, both of which say that if there is a clinical tumor lysis syndrome, then the mortality can be as high as 79%. So it was probably our luck that we actually got through this very hard phase. Answering your question, ma'am, why this patient was referred to us, this is because we have a very robust hematology department. So that's why they were suspecting this patient to have leukemia. And that's why this was a referral. This was a referral to us. And yes, and as soon as the patient came here, by the initial blood works, by that count, we were always anticipating that this was always on the cards, tumor lysis syndrome. So that's why we were kind of prepared and geared up for this. Thank you. So, last is clinical. Yeah, Dr. Madhurima Gandhi. Dr. Madhurima Gandhi, please go ahead and present it. Slideshow.
I'm not finding the cursor anywhere.
Next slide first. Next slide first. So last is your very late. Just taste.
Good afternoon to everyone present over here. So, I'm going to talk about case presentation on treatment care of a preterm baby. Now, as we all know, change taken a cursor to name. It's like should the this one. Just
change one second.
Good afternoon to everyone here. Today I'm going to speak on case presentation of treatment care of a preterm baby. Now, as we all know, preterm is defined as babies who are born before 37 completed weeks of gestation. Now, preterm babies are not supposed to be preterm, but they, due to some, either due to some maternal factors or due to some child-related factors like cord around the neck or some preterm labor, they are born preterm. And here is the case. We received from the antenatal history, the mother of this child is a primary carrier, she's 25 years old, and when we received the mother, she was at 29 weeks. She received all the vaccines and there was no history of any thyroid or diabetes. She also received 2 doses of steroids as well. All the necessary antenatal investigations were done. Doppler evaluation was done, anomaly scan was done. The expected date of delivery of this mother was on 25th of May 2022, but on 14th of March, the mother came to our emergency with complaints of recurrent left fetal movement. And after repeated USG and CGG, the gynecologist decided to have emergency NUCS on 17th of March. And the mother delivered a beautiful baby girl. Although she cried at birth, but the baby had a very poor cry with visible sinuses and respiratory distress. The baby needed bag and mask ventilation at the OT during the first steps of resuscitation. And the baby had persistent respiratory distress, was immediately transferred from OT to the NICU with oxygen support for further management. This is the head foot examination, and as we all know that premature babies have they do not have the they lack certain factors which like the premature lungs, they are not capable enough to deal with the external environment, so they need certain support system from us to breathe and to maintain the oxygenation and saturation as well. So the most common problem that they face during the first 2 to 3 weeks of life are the respiratory problems. So here in this case, the baby, after receiving from the OT at the NICU, she was immediately, since her saturation level was falling rapidly, so she was immediately put with, under CPAP with FiO2 50 and PIP6, and baby was maintaining the saturation, after which 5 ml of surfactants were given skinfully in an initial method. And as they are subjected to infections, so the test suggested a homogeneous brown glass opacity in the lungs. Capnia was given to prevent the apnea, and baby was kept under CPAP support for a week, and gradually wafting of oxygen was done. After CPAP, she was kept under a hood box. Then gradually she was under nasal cannula, and after that she was maintaining saturation at room air. This is the cardiovascular approach. Most of the preterm babies do have cardiological problems, but in this case, all the necessary investigations were done, and there was all the echocardiography reports were within normal limits. There was no abnormal sounds, H1 and S2 were present. This is the gastrointestinal system. We had done PVC insertion in a very aseptic method, and there was no organomegaly found. The umbilicus was in midline. Now, talking about the preterm babies and the GI system, the most important thing is the feeding. The preterm babies, sometimes what happens is the mother's milk is not sufficient enough for the preterm babies, and they need certain fortifiers. And this is something new that we have started in our unit. The mother in this case was not being able to have adequate breast milk, so we have started giving pasteurized donor human milk of Neuracta. We made sure that we started with a very small amount, after which when we saw that she was tolerating the feed well and there was no episodes of vomiting, we gradually increased the dose. Also before that, we gave probiotics for the gut priming, and we made sure before discharging the baby from the NICU, she was initially she was on the IV fluids and gradually feeding was established, and we made sure before discharging from the NICU, the baby was taking feed orally as well. And this is most of the preterm babies are subjected to hyperbilirubinemia. In this case, also this happened, and she was having a constant. After putting the values on the chart, it was touching the phototherapy line. So she was on and off phototherapy. Also checked for the rebound one as well. And after a few values which were constantly below the phototherapy line, we discontinued the phototherapy. Initially, her calcium level was also on the lower side, and we started with the injection calcium gluconate, which we later switched to oral osteocalcium. And although it was asymptomatic, but we switched to oral osteocalcium later. And now sepsis is something that we fear the most case of preterm babies. And due to some antenatal risk factors, like in this case it was PROM, so we had given the antibiotics in view of the low birth weight and prematurity. Initially, she was started on with Vibjo for 14 days, but after that, although her CRP level was always negative, but there was a certain rise in the total count as well, and there was few clinical signs of hemodynamical instability. So due to that, we switched to meropenem and amikacin for 10 days, and after that, at the time of discharge from NICU, we made sure that she completed the entire course of antibiotics, and there was no signs of sepsis. Neurological finding is something that we, because in case of premature babies, the brains do not give sufficient time to get matured in a protective environment in mother's womb, and so there are subsequent investigations because there are chances of intracranial hemorrhages. So to rule out that, we did certain cranial USGs, and also neurological examinations were also done. But thankfully, it was all within normal limits. Retinopathy of prematurity was also done, and it was done for the checkup was done. Was repeated after 2 to 3 weeks, but there was no signs of any ROP. OE was also done. The glucose were within normal limits, and there was normal functioning of the ear, and the plasma and bowel history baby passed urine and meconium within 24 hours of life. Along with OE and ROP, 7 condition tests were also done, the newborn screening. These are the vaccinations which the baby received. Injection vitamin K were given at the OT itself to prevent hemorrhages. And BCG, OPV, and hepatitis B1 first doses were given. These are the discharge advices. Before discharging the baby from the NICU, we made sure that the baby was done moving in with the mother, because these are all the aspects for the premature, for the care for the preterm baby, which mother look for at home as well. So the long-term follow-up was the neurodevelopmental assessment, because to make sure that this baby is at par with her term counterparts, and in comparison with the term babies, the preterm babies need supplementations of calcium, iron, and vitamins. So all these were given to the baby as well. And this is the picture at birth. The baby was on the left-hand side, and this was before discharging from the NICU. At present, we have these 2 twin babies weighing 800 and 840 grams, delivered by emergency, normal delivery due to SROM. Both the babies are now under CPAP, and they are having IV antibiotics and all other supportive medications are given. Thank you. Thank you.
So we have the results. Shubhadeep?
Yeah.
Judges are Thank you very much to both Amitabh and Shubhadeep and your teams. Very good presentations. Next time is to I think standard is 5 minutes. J 5 digital kind of one. No, we can count it. Digital blue. They are good to attention span blue. I learned many new things. India is a basic. Okay, first prize, Manisha Rao.